What I really wanted to focus on for this talk is some of the clinical work we've been doing. I've talked about some of my basic science projects, but I really wanted to bring it back to the mission of the Stone Center, which is mainly to try to improve the lives of patients, both by improving our understanding of the basic mechanisms of kidney stone formation, but also just how we can improve their treatment, right? And so in that vein, I'll be talking about the clinical projects that I've been substantially involved in over the past year and a half or so. I wanted to sort of talk on two fields, which would be stone management and then instrumentation. So the first three projects we'll be talking about are our evaluation of shockwave lithotripsy, specifically in distal ureteral calculi, an evaluation of 24-hour urine analysis, which you'll be a little bit familiar with from Louisa's Lauren Sullivan talk earlier this year, and then an investigation into antibiotic management for struvite stones. Then we'll switch gears and look at instrumentation, and we'll start talking about some of the new things that have been happening in terms of single-use ureteroscopes and cystoscopes, and then we'll talk about some access work that Connor has been spearheading for us. So our first project is looking at ESWL and how efficient it is in the management of distal ureteral calculi. So the ultimate goals of any stone intervention are to achieve maximal stone clearance, but to do so with minimal morbidity to the patient. Because of that, ESWL and ureteroscopy are generally used to treat distal ureteral stones. However, AUA guidelines have now recommended that ureteroscopy be the first-line management for stones in this region. We've been doing lots of shockwave lithotripsy here at the Stone Center, and we thought that we had been getting good patient outcomes. And so because of that, we wanted to tease out whether our outcomes were actually as efficient as we thought they were. It turns out that there have been several meta-analyses done comparing shockwave lithotripsy with ureteroscopy in the ureteral calculi. We know that ureteral calculi tend to have higher stone-free rates with ureteroscopy. But we also know that shockwaves are associated with fewer post-op complications, shorter OR time, and shorter hospital stays. And it turns out that a lot of these studies have been done either in proximal ureteral stones or pan-ureteral stones. And there are only two older publications looking at distal ureteral stones specifically. I also wanted to just note here that we found that there's no strong evidence associating shockwave to long-term adverse effects. There had been some initial studies that had suggested that potentially there might be effects on hypertension, diabetes, that sort of thing, but there's no increased incidence of any of these hypertension, diabetes, kidney disease, or infertility. And so our hypothesis was that shockwave would in fact continue to be an effective treatment option in the management of these stones. What we did was to evaluate patients who had distal ureteral calculi and presented to the Stone Center between 2011 and 2017. And then we investigated their post-shockwave outcomes. We looked at success rate of shockwave lithotripsy assessed as stone-free rate via both radiologic imaging and the need for subsequent procedures in the patients. All right. And so what we found, we had 76 patients, almost 60% male, with a maximum stone diameter of 6.9 millimeters. And what you see here is, if I can get my, nope, not gonna happen, sorry. So what you see here is that for a single stage shockwave procedure, there's a 78% stone-free rate. Thank you. Which goes up to 90% with two procedures. And then also what we found was that for those patients who required a second procedure, about 10% of them ended up having a requirement for ureteroscopy. So 78% first stage procedure we thought was reasonable. And then 89% after two. What we determined from that was that shockwave was still an effective modality in the treatment of at least distal ureteral stones. But we recognize that there needs to be more rigorous looks at this. And so a prospective RCT is necessary. And in fact, with a newly set up international consortium, the Tower Consortium, we and other international groups will be looking at this specific question and trying to randomly set up our patients and get answers to this question. Okay, so stone prevention. I'll be switching gears from project to project, so just bear with me. But studies evaluating the effect of dietary measures on stone prevention are largely based on retrospective data. And really, the data has been quite old now. One of the more recent studies, and one of the few studies that has really looked at general recommendations for stone patients as compared to targeted stone patients, was in 1999. And it was a prospective multi-year RCT that argued that, in fact, specific dietary therapy is more effective than general recommendations. Now, what do the guidelines say? The CUA guidelines state, and I quote, that individualized approach to dietary and pharmacological prevention would be necessary for recurrent stone formers. And they recommend that in order to follow these patients, at least 2 24-hour urines need to be done. EAU actually recommends general preventive measures and then a targeted diet only in high-risk patients. They also want a 24-hour urine times 2, but then annually after that. And for the AUA, while they also want annual 24-hour urines, they want stone-specific dietary advice. And so the guidelines are similar, but not exactly identical. What are some of the general diet recommendations? I just wanted to go through quickly. Fluid intake, we all know that we're asking patients to drink lots of fluid. We tell them to drink at least 2 liters, in some cases 2.5 to 3 liters a day. We want them to eat a balanced diet, and with the hopes that a balanced diet would incorporate all the things that we want: rich vegetables and fiber, less fat, normal calcium content, limited sodium. And then we ask them to address their lifestyle choices so that they can maintain a normal BMI, etc., etc. And some of the targeted recommendations include things like looking specifically at what the patient's issues are. So for patients who have hypercalciuria, for instance, we would recommend pharmacologic approaches, including the addition of thiazide and potentially potassium citrate. And then with hyperoxaluria, oxalate restriction, etc., etc. I just wanted to give just a quick example of a 24-hour urine analysis, because we'll be talking about that in a little bit. And here, this is a sample litholink report. And what you see here is, just like we do the 24-hour urines here, we're looking at volume. They're able to look at supersaturations, which is nice, but we're also looking at just levels of calcium, levels of oxalate, levels of citrate in the urine. And then we're also looking at dietary factors, trying to figure out on a serum level what's their magnesium, what's their chloride, what's their calcium, that sort of thing. And so we think that helps us when we're trying to recommend to our patients what they need to do to prevent stones. But is that actually the case? And so in a study that we did with Louisa, and she presented earlier this year, we found that the 24-hour urine collection has a limited role actually in kidney stone prevention. What we wanted to do to begin with was to evaluate whether, again, targeted medical therapy based on the 24-hour urine collections versus general therapy recommendations will affect the rate of stone occurrence and then repeat 24-hour parameters. We identified stone patients who were seen at our clinic between 2013 and 2015, found 95 who underwent a metabolic workup, including 24-hour urine collections at least at 2 points, and then we retrospectively performed a chart review. We looked at change in 24-hour urine parameters after they received either general advice or targeted advice based on their stones. And then we looked at stone recurrence after they underwent their metabolic evaluation. We had 49 patients who underwent general dietary advice and 46 who had targeted advice. Other than that, there weren't that many changes in terms of our patients, apart from our percent male patients here. But one of the things that we thought was interesting is that there were 65.2% of our targeted advice patients had bilateral stones. Okay, and we'll get to that a little bit later. So the rate of stone recurrence in the patients who had received general dietary advice was actually about a little bit over 40%, as compared to those who had targeted advice, which is actually over 60%. And then in terms of repeat 24-hour urine parameters, the percent of patients who had improvements in their 24-hour urine parameters was actually higher in the targeted advice patients as compared to the general advice patients. And so what can we conclude from that? Well, it seems like general advice is maybe sufficient for most patients. And we think that the 24-hour urine is playing a limited role in directing long-term management plans, specifically because we noticed that even in the patients who had targeted advice and whose 24-hour urines improved secondary to that, those patients had recurrent stones. Now, the interpretation of these results might be limited by the fact that the urine collections might have been inadequate. The sample size was certainly small. And there's a question of patient knowledge and adherence. Did they actually follow the advice they were given? What did they know ahead of time? And then when we talk about targeted advice and people having recurrent stones, potentially there's some bias there because these patients might have been the patients who were more high risk. All right. So what needs to happen is that future studies randomizing targeted advice to general advice would need to be done, and that those would hopefully determine if 24-hour urine tests are in fact helpful. But certainly there's some question here based on our study. And I just wanted to stop here quickly and just mention that this study all came about because when Dr. Stoller had his visiting professor last year, we had a conversation about 24-hour urines, and he mentioned, I don't know if the residents remember, he mentioned that he didn't really trust them. And we got into this little side conversation. So, sometimes ideas come from the most unlikely places. Okay. So our third study is one that I'm going to show just preliminary data for, and this is something that I'm hoping that we'll be able to get all the data together for before I leave. But it's an EDGE Research Consortium study looking at the antibiotic management for struvite stones. So the question here is that the appropriate regimen for postoperative struvite stone management is not really clear. And urologists will prescribe anything from a week to several months of antibiotics for these patients. And so our hypothesis is that a week of postoperative antibiotics may in fact be sufficient for proper management of struvite stone patients. And what we're doing is performing a multi-institutional prospective RCT, comparing patients prescribed with 1 week versus 3 months of antibiotics, status post-definitive struvite management. And so again, like I said, we just have preliminary data from our center here, but there are a couple things that were interesting I just wanted to mention quickly. We currently have 23 struvite stone patients. So for the urologists in the room, if you come across somebody, please send them our way. We'd like to increase our numbers. 18 of those patients are female. The mean age is 46. Most of those patients, it turns out, are overweight. And their Charlson comorbidity score is actually quite low. We tend to think of struvite patients a lot of times as having many comorbidities, but that doesn't seem to be the case in our cohort. And then the previous stone history seems to be almost 50-50 here. Unfortunately, most of the patients who did have previous stones did not have them sent for analysis. Okay. And then in terms of how many stones these patients present with, it seems like there's a real mix, but potentially, less than 3 or so stones seems to be more common in our patients who present to Stone Center. And again, similar to what we've all read, most of these patients have complete Staghorn calculi. Okay. So then just a brief analysis of UTI and urosepsis. It turns out that the majority of these patients don't have positive preoperative urine cultures. And in those patients who do have positive cultures, they tend to be, at least in this cohort, mostly Proteus. And then most of our patients, thankfully, do not develop urosepsis. Okay. Most of our patients already have been exposed to antibiotics within the 3 months prior to their surgery. And they've been taking them for several weeks, as you can see here from our mean number of weeks of antibiotics course. So what are our findings today? They're mostly female. They tend to be overweight. They tend to have complete staghorns. They tend to have negative pre-op cultures. Those with positive cultures tend to be proteus. And we don't have a high rate of postoperative urosepsis. So like I said, we're continuing to look at this data and we're continuing to accrue patients, so please send them our way. Hopefully we'll be finishing this up in the next several months. All right, and then I'll switch gears entirely and start talking about instrumentation and stone access. So one of the first things we did when I came here was to look at single-use ureteroscopes. Until recently, reusable ureteroscopes had been the only tools available really to perform ureteroscopy. But since 2016, we've had new single-use ureteroscopes, which are attempting to address some of the disadvantages of reusable scopes, namely the costs of scope acquisition, of maintenance, of repairs, of processing, and of sterilization. So one of the things that proponents of single-use ureteroscopes have been talking about is the avoidance of infection. There are many papers that have introduced this idea that patients are actually having urosepsis secondary to contaminated scopes. And then there's also this issue of the cost of continuous maintenance of these scopes, of repairs when they do break. Now, based on the recent literature since these scopes have been introduced, there may be likely cost savings for high-risk breakage cases. So we're talking about cases where you have really difficult to access lower pole stones, where you have tight infundibula, where you have a staghorn stones that for whatever reason you can't treat with PCNL. And at least one paper is showing that there may be savings of up to about $230 per case if you use these scopes. And there may be possible cost savings for routine cases. And the reason the data is inconclusive is it seems from the multitude of papers and studies that have been coming out on this that it really will depend on the volume of patients that you take care of at your institution and what your costs of repair and maintenance are for your reusable scopes. So the jury's a little bit still out on that. So what we wanted to do was to look at single-use, flexible and semi-rigid ureteroscopes and to compare how they performed compared to reusable ureteroscopes. Okay. I just want to give a timeline here because there's just been a profusion of these scopes and there seem to be more on the market. So I just wanted to give a sense of what we have available. So some of the first scopes that were available included the LithoVue from Boston, and that came out in January of 2016. And there's some question as to whether the first generation Use scope from Prusin Medical came out around the same time. And then in the spring, NeoFlex and NeoScopes came out. Now the NeoFlex scope is a flexible single-use ureteroscope, and the NeoScope is the, to this date, only semi-rigid single-use ureteroscope commercially available. And those are both by the NeoScope company in California. Then Prusin actually sent out a second generation Use scope, and that's what most people have been using to date. Followed by the Shaugan scope by UCare Technology, which is not available in Canada, but has certainly been around in some areas in Europe and Asia. That's also been termed the YCFRA, so you may have seen that term instead. All right, so what we did was to compare benchtop and clinical parameters. And for our specific study, we looked at the LithoVue, the Use scope, and we compared them to the FlexXC digital flexible reusable scope. And then we performed a review of the literature evaluating all of the commercially available single-use scopes as well. So just in terms of the manufacturer specifications, I wanted to point out a couple of things. One was that most of these flexible scopes tend to be larger than what we're used to with the, for instance, FlexX2 fiber optic. But the LithoVue is the largest diameter, scope 9.5, as well as the specifications for the secondary Use scope. Some of the others are smaller. You'll notice that the YCFRA is 8 French, which is even smaller than the Storz reusable FlexXC. And we'll talk about why that is in a little bit. Working channels are all about 3.6, except again for the YCFRA. And then in terms of deflection, all of the scopes have bilateral deflection around the range of 270 to 280 degrees, except for the YCFRA, which is unilateral. And it turns out that the Shaugan scope is, per their reps being upgraded to a bilateral scope. So we'll be talking about that, I guess, at some point in the future. They all use CMOS technology, and they all use LEDs for illumination, except for the Poussin scopes. And they all have a light source in the handle. Oh, let me just go back 1 second just to talk about the semi-rigid scope. There's not a lot of published data on this scope. We've used it here. Well, I used it in Dominica, but it's not really been published. That said, it also uses a CMOS and has an LED illumination source. So we did a video just comparing, as I said, sort of the benchtop and clinical parameters of the three scopes, the Poussin, the Storz, and the LithoVue. And in terms of specifications, we found deflection up and down to be in the 270 range. And in fact, we found that the diameter of the Use scope was 9 French as compared to 9.5. So it's a little bit smaller than the LithoVue, but both are larger than the Flex XT that we're used to. Same working channel, CMOS imager. And then what we did was to look at deflection of all three scopes with an empty channel, with a basket in, and with laser fiber. And what we found that with all three scopes, the LithoVue scope actually ended up having better deflection. And you can see here, just looking at upward deflection, the tidal curl with the LithoVue scope, and for downward deflection as well with all three scopes. We measured shaft diameters and found that they were pretty consistent compared to what was told to us by the individual companies. But again, the LithoVue seems to be a little bit larger than the Flex XC. Irrigation flow rate was the same in the Poussin scope as compared to the Flex XC, but improved in the LithoVue. And then we looked at a variety of imaging parameters. So we looked at things like, sorry about that. We looked at things like distortion. We looked at things like color fidelity. We looked at things like, give me 1 second here. Yeah. We looked at things like field of view. And what we found, and image resolution, and what we found was that the Flex XC was superior in all of these. That said, sorry about that. That said, the LithoVue and the Poussin scope were comparable. Okay, so then we did a clinical evaluation of all three scopes in the same patients. This is the Poussin scope, the LithoVue scope, and the Storz Flex XC as well. And you can see that they all get to the lower pole nicely. And this is the difference in the visualization with the Use scope and the LithoVue here. And we compare both of those to the Flex XC. And then just to give you a sense, with the XC, the fiber optic scope as well. So you see the difference there in the visualization. But our conclusions were that the single-use scopes were comparable to each other and to the reusable digital ureteroscope in terms of flexibility, in terms of the ability to reach all calyces, in terms of visualization, not as superior as the Flex XC, but certainly comparable, I think. And in terms of the ease of use of accessories, like I said, we looked at various baskets, we looked at laser fibers, and with an empty channel. And then in terms of the comparison of these scopes to the reusable scopes, we think that there are some advantages. We found improved ergonomics. They were certainly lighter than the Flex XC. And again, there's this idea that you can use them in more challenging cases since you don't have to worry about damaging the scope. And again, the idea of costs is up in the air, but potentially there may be some advantages there. Okay. So the next thing we looked at was a single-use flexible cystoscope. So the Neoscope company is, as of right now, the only company with a commercially available single-use cystoscope, which we were able to use during the mission trip that I took earlier this year to Dominica. And the thing that's interesting about this cystoscope and also the Ureteroscope that they offer is that you don't actually need a tower. So what you see here is the scope connects to a dongle, and that dongle can be directly connected to any monitor, including a laptop. So it allows for significant portability. And so you see me here performing a cystoscope on a patient in a clinic. I'm just using my laptop. All you need is your scope, irrigation tubing, and your laptop, and you're good to go. So what I did was to make this into a preliminary study where we were able to evaluate the performance of these scopes in a difficult circumstance. Okay, so in an island post-hurricane, some of the issues with having reusable scopes in those kinds of circumstances is there's no technical support for reprocessing. There's insufficient space. There's definitely no funding for auxiliary towers and monitors and those sorts of things. And in this particular circumstance, there was limited availability of electricity outside the capital city. And so with a scope like this, if you're able to charge your laptop, use it anywhere, whether or not there's electricity, take it anywhere in and out of the hospital. All right. So what we did was to perform flexible cystoscopy in clinic and in patient bedside settings. And so what I just wanted to do was just show a very quick video of what the visualization is and what the handling is of this scope. So we're going up the urethra, and this is a case of a patient who was brought into the hospital. He was not really very responsive. He was query urosepsis with massive ascites, and they weren't sure if he was anuric or just in retention. So this is me going up his urethra, and it's taking a little while. But you can see from the visualization, you can see what's going on. You can see the tissue reasonably well for that situation. And it turns out that this patient just had massive BPH. So it took a little while to get up there. When we get into the bladder, what you'll notice is that visualization decreases significantly. So this is me fighting to get up the prostate. So bear with me for a little bit. But from our perspective, being able to see what we need to see in that sort of circumstance, we thought was worthwhile. And it wasn't that difficult to steer, but it certainly is not as easy as the reusable scopes that we have in clinic. Yeah, so we'll talk a little bit about the fact that the color representation is not really there's not a lot of fidelity with the color representation of these scopes. And I should say that I was using prototypes. They are now moving on to second generation scopes, which supposedly have dealt with some of these issues. I'll talk about some of the other issues that we had in just a minute. So some of the pros, I thought, were that there was no external processor needed. It was easily portable. The illumination, I thought, was adequate. I could see. And the image quality was decent. Again, it's ideal for use in rapidly changing settings. Some of the cons were what we discussed here with the imaging. It's not the best. And the scope shorted on a few occasions. So it turns out that if there's any water anywhere near the connection for that dongle, that the scope is short. We've been promised by the company that that's been addressed. And as a result of that, we've moved on to have an international multi-institutional study with some of our colleagues in Zimbabwe and Egypt, trying to look at this scope and compare it to reusable scopes. I don't think that this is a scope that's ever going to be widely used here in North America. We have very good scopes, but in a situation such as I mentioned, I think that there is some value to something like that. And so what we're doing is comparing the performance of the Neoscope cystoscope with reusable scopes. And we'll be using 5 consecutive cases at each center, and hopefully I'll be able to talk about what the results are in the next coming months. Okay. So the final topic under discussion will be our evaluation of an ex-vivo pig model for teaching percutaneous access techniques. And this work has primarily been done with Connor Forbes and two of our students, Jonathan and Justin. Connor already presented this for his Lawrence Sullivan talk, so I'm not going to belabor it except to show a little bit of what the model actually is, and so that people understand what we were actually doing. So again, just a quick background that decreasing numbers of urologists are getting their own access. And since lots of data show that greater stone-free rates are achieved when urologists perform their own access, we hypothesize that it would be an important thing to get trainees and urologists who were interested in incorporating PCNL into their armamentarium to compare the different ways of learning how to do this. There's a steep learning curve requiring at least 60 procedures. And while simulation models are useful as a training tool, it turns out that many of the models are not as useful to trainees as, for instance, a live pig. The issue with having live pigs, though, is that they're very expensive. And so in collaboration with the folks at Cook, and I want to here acknowledge our Cook representatives, including Brad Whittle, who's been very helpful with helping us to get this together. What we do is the following. So this is just a very quick video of how we set up this model. It's an ex vivo model where we're using pig parts to simulate the human's circumstance here. Okay, so what we do in the setup is we have kidney with ureter attached, and we use flank tissue above that to simulate sort of the tissue within the human. We cover those flank pieces with ribs, again to simulate the circumstance. And then in that whole setup, we would like to also cover with subcutaneous tissue and a very tough skin, since those are the issues that people have to deal with in trying to get access in humans. First, we then take a retrograde catheter and we connect that to the ureter. And you can see here that you can get your retrogrades for visualization. You see the ribs there, performing a hindrance. We're able to use both the bullseye and the triangulation approach. We're able to then get access to the kidney. We're able to advance a guide wire as is required for maintaining your access once it's achieved. You can use the C-arm to follow the wire and do all the things that you would do for a normal PCNL. And then once that's done, you're also able to do balloon dilation and sheath placement. So all of the steps that you would need to do to appropriately achieve access. Okay. As I mentioned, the things that we were thinking about with this particular model is that it's as close to a live pig as you can get while avoiding the costs of a live pig, which is almost $2,000 per pig. With this model, you're just looking at your rib block, you're looking at your skin, you've got your kidney, you've got flank slits, and miscellaneous charges, which is about 217 or so Canadian. And then with each extra pig, all you're adding is an extra kidney. You can continue to use this for a whole session, and then based on how many trainees you have, you just add extra kidneys on. So we think that it's something that would be reasonably cost effective, but appropriate for training. So we provided hands-on training to residents as well as urologists interested in learning how to obtain access. We used the ex-vivo pig model. We also used a silicone-based model, which we then asked the participants to compare. We gave questionnaires at the end of the course. And Connor already talked about this, that most of our responders had not had previous experience obtaining access. Most of the trainees had thought that 93% thought that the pig model and 79% thought that the silicone model was easy to use. Most of the pig model trainees were confident in their ability to obtain access after the training, as compared to only half of the silicone model trainees. And all of the pig model trainees felt that the simulation activity was worthwhile. Okay. So we think that the cadaveric model scored well, and we think that the accessibility of the components then allows for implementation of this model in urology training programs. We recognize that there are some limitations. There was a single center study, there's a questionnaire, there's a limited sample size, and there may be some confounding variables, but we think it's an interesting option for teaching trainees and certainly established urologists. All right. And so I think I'm still on time. Just some take-home messages. I know it was a lot of different topics, some of them more related than others, but the two take-home messages I think are that the advances in technology and tools in the urologic armamentarium that have been in recent years might allow us to provide safer and more efficient care to patients, and certainly training for residents. And then also that questioning some of the dogma underlying stone management with respect to, say, struvite stones and 24-hour urines might actually improve patient outcomes and satisfaction. And on that note, I will end here and take any questions.